What are your overall thoughts on clinical trials? I think this is something that both of you could have some insight on.
Yeah, I could start. We, in general, are such strong advocates for considering clinical trials. And I think one of the challenges is across the different types of cancers and disorders we treat in medicine, patients with cutaneous lymphoma are often left behind because there are fewer trials for patients with rarer conditions. And I think that really is one area we really need to improve on as a community. And so if you're able to seek out opportunities to participate in clinical trials or understand where they might be offered, I think it's really important to consider whether that would be logistically feasible for you to at least get more information about. We know that we have a large toolbox of therapies, whether skin-directed or systemic oral pills or IV, but we know that there's such an unmet need even despite that presence of existing treatments for us to improve everyone's long-term success rates who live with this condition.
Is there any way to predict length of remission following treatment with Adcetris?
I could take this question. So for those in the audience who are not aware, Adcetris is one of the infusional IV targeted therapy agents that we have at our disposal to treat patients with cutaneous lymphoma, most commonly people with mycosis fungoides, Sézary syndrome, and another condition called anaplastic large cell lymphoma. Like many drugs that are explored, they're meticulously studied to understand their side effect profile, how well they work across a broad range of patients, and we do have that data. But one thing I think is so important to highlight is, as many are aware, the world of cutaneous lymphoma is really exemplified by the word heterogeneous, where you can see such a wide range of people who have excellent responses to treatments or those who do not respond as well as we'd hoped. And so it's very hard to assign a specific number or rate of response or expected percentage of response for any single person. Depends on what medical conditions a patient might have, the characteristics of the lymphoma that they're facing. But the hope is that we can thread a needle and use a treatment and find it to be effective, and if so, continue it for as long as possible with acceptable tolerance. Some patients I treat with Adcetris can have many months or even years of control of their lymphoma, but other patients run into either side effects sooner than that, or we find that the lymphoma is unfortunately not responding as we'd hoped sooner than that. So I think what's really important here is to make a shared decision with your healthcare provider about whether it's something that is worth trying after examining the risk and benefit, and then following closely to understand whether things are responding as expected or whether there are any unforeseen complications arising.
How much radiation is too much radiation? I'm approaching my 15th round of targeted radiation in 8 years.
This is a great question, and again, it's very complicated. There are many kinds of radiation that can be given. And what matters is going to be the dosage, the type of radiation, the specific locations. And the only way to get a good, hard and fast answer to that is to talk to the radiation oncologist, who would have to review your records and discuss your case with you specifically. There are certainly limits, but they would be best able to evaluate your specific case.
Does successful topical treatment for patches plaques mean that they clear, go away? I've been treating patches for 6 months and they have not cleared or reduced in size. Is a new treatment plan warranted? What would you recommend for a patient that's experiencing this?
So this can be a tricky question because when you have patches and plaques, even if they're treated successfully, you can actually end up with post-inflammatory hyperpigmentation, which leaves like a shadow of pigmentation in the area that the patch or plaque was. So you may still have areas that look different to your normal skin, but they may not have active disease. So I would want you to show those areas to your dermatologist and ask if they think that there has been clearance or if there's just residual hyperpigmentation. If the areas are not bothersome to you, then you may be able to just continue as you are. If they continue to be itchy and bothersome, then I would have you discuss that with the dermatologist and see if a different topical treatment might get you better symptomatic relief.
Please discuss the advantages, disadvantages of steroid ointments versus non-medicated ointments. Should steroids be used regularly or only during flares?
So topical steroids are a mainstay treatment for all cutaneous lymphoma, T-cell lymphoma patients, and most people use it for flares regularly. And sometimes it takes a few weeks or even a month to get the flare under control. But in general, you do want to take some breaks because topical steroids can cause some skin thinning if they're used day after day, month after month, and thin skin can bruise easily and get tears. So we do recommend breaks. And given that, if you find that topical steroids are not enough to control your skin T-cell lymphoma, then non-medicated topicals can be useful for long-term management. But some patients are actually on both because topical steroids work fast. That's the main advantage.
Dr. Kim, could you address the use of like moisturizers or emollients in patients with cutaneous T-cell lymphoma?
Yes, they're incredibly important, and we recommend that you follow a gentle skincare regimen and moisturizers. There are differences in moisturizers. We generally recommend a thick cream or an ointment-based moisturizer rather than a lotion. Most patients initially use a lotion and it comes in a bottle. It's very easy to put on quickly and it dries quickly, but it's actually not very moisturizing because it has a high alcohol content. So we want patients to use a cream or an ointment.
When patients are being treated with a systemic therapy, oral or injectable, but still have a few bothersome patches or plaques, do you offer a topical treatment in addition?
Most definitely. And I think we can both answer this, right, Dr. Fitterbrand? So I would say that topicals are important, are the main player in early stage disease, but even in advanced stage disease, it's useful to have it as adjunctive treatment. And so I would say that it's very common for patients to be on the combination treatments.
Does brentuximab carry long-term side effects?
The biggest side effect from brentuximab vedotin is called peripheral neuropathy. It usually manifests as numbness or pain in fingertips and tips of toes that then kind of, as it goes on, progress up the hand or foot. That can be reduced by reducing the dose of the drug and sometimes even lengthening the time in between doses. And I would say that is the biggest long-term toxicity of that drug.
Is topical steroid enough? Does not doing any therapy alter the course? And we're going to have a different question later that's kind of along the same path.
I think it's important to clarify what stage you are. That I think is pretty important. I think most of us feel that for very early stage disease, particularly stage 1A, and if you have patches less than 10% of your body, then what we call active observation or surveillance, active surveillance, can be acceptable. And it is recognized on certain treatment consensus guidelines, like for instance, the ERTC ESMO guidelines. Because for early stage disease, truly early stage disease, we don't have great data that being aggressive about treatment in that patient population changes overall survival or decreases the risk of progression. For anything above stage 1A, I would say that it really depends on the patient, their disease tempo, if they have patches or both patches and plaques, if they have a history of infection, if they have severe itching. All of those factors play a role in the doctor's recommendation to treat. Because if you were severely itchy, scratching your skin, you're at risk for infection, and then treatment would be very important to get that itch under control because we don't want you to get infected. But as I circle back, for selected patients, active observation, or at least periods of time if you have very minimal skin activity, is okay. If I circle back to topical steroids, is it enough? For some patients, yes. I would say in my practice, about 1/3 of my early stage patients are managed with just intermittent courses of topical steroids and periods of active observation. But that means 2/3 have to move on to something else.
Next question, are This is a good one. Are there any permanent solutions for itch?
Yeah, this is a very, very important topic, and one where we need more options. Well, so there are treatments that the most important thing is to treat the underlying mycosis fungoides, cutaneous T-cell lymphoma. Whatever cutaneous lymphoma that's causing your itch. Treating the underlying cause is really important. But it is true, many patients, even if you are actively treating the lymphoma, you can still have quite difficult itch. So there are topical things that you can do. There are oral systemic therapies you can do, and on the horizon, probably some IV therapies. But none of them are quote unquote permanent. What I would say is treating your underlying disease is the most, if you get into remission, then that will hopefully be durable and long lasting. Some of the, things we use commonly for, oral agents are like antihistamines, things like gabapentin or pregabalin. We also use some low dose of antidepressants like mirtazapine. There's even anti-nausea medicines like aprepitant. So we have a lot of tools in our toolbox, and it's a matter of just trying them. But I know that we probably need more.
Another
Thank you.
aspect of this is, I guess, two comments. One is back to the moisturizers, because if you have dry skin, it itches like the devil. So that's not so helpful. And number two, if you listen to Dr. Kim, a lot of the treatment options that she's mentioned aren't antihistamines that people would generally think about when they're treating people with itching. And the importance of that is that the itch pathway in patients that have cutaneous T-cell lymphoma is really mediated by nerves. So a lot of the drugs that she mentioned are things that neurologists use for other purposes, instead of things like Benadryl or drugs that oppose histamine, because the pathway here with the itching is very, very different than in other conditions.
On our next one, are there any, oh, we missed Smith. We'll go to, how do you know if MOGA is working?
Well, mogamulizumab, it works really quickly in people's blood if somebody has blood involvement. And you can tell that by, I guess, initially looking at the blood counts and then looking at things like flow cytometry. It works a little more slowly in other areas like the skin. And it's an antibody, so it doesn't work incredibly rapidly like some other things might. So how can you tell if it's working? If somebody has blood involvement and perhaps on a blood count they have a lot of lymphocytes and you see them going down, that would be a good sign. If the flow cytometry has less and less and less cells and sometimes has no cells, that would be a good sign. And then kind of lagging behind, you see the skin improve and the itching, if there's itching, improving as well.
So the second half on that question was, what are some options for next steps if MOGA isn't working?
It would depend on the patient's stage and type of disease. So I would say in my practice, mogamulizumab is used most often in patients with Sézary syndrome or total body redness. And my next treatment option, though there are many, might be something like an HDAC inhibitor like romidepsin, though there's other options as well. And your specific physician would know, in your case, given your overall health and status, what might be the next best choice.
Thank you.
I'm just going to pipe in really quickly that mogamulizumab can cause a dermatitis in a fair number of patients, 20% in the clinical trials, but at the centers in kind of real world data, it's closer to 50 to 60%, and it can look very, very similar to CTCL clinically. So if that, I think whenever you have a rash that's not getting better or suddenly got worse on MOGA, it would be good to see a dermatologist, undergo a biopsy, have it read by a dermatopathologist who is experienced with the nature of MOGA dermatitis, so that you don't prematurely stop the MOGA, and you can treat the MOGA dermatitis with topical steroids or prednisone or phototherapy or methotrexate, and try to treat through and then still gain the benefits of staying on the MOGA.
My oncologist recently introduced the concept of a stem cell transplant. In your experience, I want to add that in, at what stage in a CTCL-MF journey might stem cell transplant become a reasonable treatment option? What makes a candidate suitable for transplant, and what is the success rate?
That's a very difficult question, and I'll take the questions in a different order. So what makes a candidate suitable would be that you have an acceptable donor, that you don't have a lot of comorbid conditions that would prevent a safe transplant. If you could put the question back up, though, it would be really helpful. And the success rate, weirdly enough, the success is higher when someone has Sézary syndrome or erythroderma, meaning that their skin is totally red, versus a patient that has large cell transformation or tumors. And then going backwards, at what stage in a journey would it become reasonable? That's such a hard question. But I think there would be an interplay with the stage or the nature of the condition and what other treatment options remain, as well as the patient's age.
Is there an average length of time that mogamulizumab will work as treatment? If a patient is developing a few new lesions while on this treatment, does that indicate that perhaps the treatment is not working as well?
I think that if they are developing new lesions, I think it's just important that they get their skin assessed. One of the things in relation to mogamulizumab that we do see is this mogamulizumab-associated rash. It's very important that that's distinguished from a side effect of the treatment versus actually the disease itself. So it's important that that's evaluated by their dermatologist to see what is happening, because that is important. Yeah.
Yeah, and as a general strategy, it sort of depends when, with new lesions, it kind of depends on what exactly is going on. If there's maybe one particular area that's, troublesome, maybe we can add, some radiation just to that area. Maybe we can do something more targeted for that area. If it seems like there's a significant number of new lesions, then, potentially changing treatment is warranted. Of course, after having an exam, ruling out this, treatment-associated rash. So it's kind of individualized, I'd say.
Is there any other option besides going MOGA every 14 days for the rest of my life? Will this flaky rash ever go away?
I'll take the first question. It sounds like the person has gone past the initial month of mogamulizumab, which is weekly, and then every other week. The short answer is that the way that the drug was studied, that it continued on for patients continued to take it as long as their disease was in remission, every other week, until there was possible progression of their disease. There are some people trying to look at other ways to do that, but that's all in investigational form at the moment. And that's also a conversation to have with your own primary oncologist.
Thank you. And for the other part, our goal is always to get this better with treatments. And how I always like to phrase this with my patients is that if you had psoriasis or eczema, it would be a similar story. We often don't get this to ever go away, but we have lots of tools and tricks to kind of keep it at bay and have it have a minimal impact on your life.
With CRISPR in the news regarding actual editing out of a disease from cells, is that a viable area of research for people with T-cell lymphomas?
It's going to be tough to say what any anything that can kind of scissor or take out disease itself, how it's going to extrapolate into T-cell lymphomas itself. I think part of it in terms of you'd have to know some of the different targets and the like. And we still have a long way to go in terms of trying to figure out exactly how to do that. So great question, and lots of interesting technology there. And we are doing our best and continuing to work on it.
What new treatments can put CTCL in remission? And this one's a little bit of a loaded because it depends on what you determine as a new treatment.
Yeah, I think the way to answer that is that similar to the earlier question or conversation, is that we are doing our very best in terms of, working on new treatments, different sorts of immunologic responses, thinking about as we try to get closer to what the actual inciting event is for mycosis fungoides and cutaneous T-cell lymphoma, that also helps. Any number of our treatments can put patients in remission. I think that the best way to find out in particular in terms of what is new or what is on the horizon is always to you can look at the NIH website in terms of looking at what kind of trials we have across the country and around the world on CTCL. And I mean, our goal is, of course, not just remission, but an extended remission as long as we possibly can. But we have different subtypes of therapies, as well as others are looking at combinations of immunologics and trying even combinations of single agent therapies that we've done in the past to see about remissions, even if somebody's disease has progressed. So that's a number of different approaches.
Okay, thank you. We have a follow-up question to a previous answer you had given is, can you please explain inciting event a bit more?
So for some people or some types of cancer, there may be a risk factor and or from a genetic point of view, some reason why within the genetic code that there's a change. Other things that people have looked into is and have not panned out are viruses. We also know that there's a close connection between skin-related cancers or mycosis fungoides and bacteria, particularly Staph aureus. And so a number of those things are why this happens in certain people and why it doesn't happen in many other people is the event or the events molecularly that we're trying to look at.
Is targeted radiation, so in your opinion, from what you have seen, is targeted radiation the best approach to a bump that was cut open, cleaned and stitched, and later learned to be PCMZL? There are no clear margins or they are unknown, and PET scan showed no cancer anywhere at all. Options are to do nothing or accept what seems to be low-grade, shallow targeted radiation where the spot was. So this is very patient-specific. So I think I should maybe phrase it as, have you had any experiences like this?
Well, I'm smiling because I think Zach and I might have the opposite answer just by some of the patients we have together. But Zach, do you want to go first?
Well, I'm guessing it sounds like they were treating this, well, in general, it sounds like based on this, they're treating it as a cyst or something. And based on that, usually they don't submit this for margins. So the pathologist can't clearly assess if it is or isn't out, which as pathologists, assessing margins for lymphomas is very challenging. It's not like a normal other cancer. So that in itself is a separate issue. But I would say from the data we have, either surgical excision or radiation for this can result in a 50% cure rate, especially for whether it be primary cutaneous marginal zone lymphoma or primary cutaneous follicle center lymphoma. If this was considered an adequate excision, you could leave it at that. If you're feeling extra cautious, you could consider radiation in this scenario. The other thing to consider is marginal zone lymphoma can be due to chronic antigenic stimulation. So I'll just talk with your provider and get a thorough review of systems just to see if there's anything else going on that could have triggered this. So this could be like an H. pylori infection, which causes GERD, or this be an autoimmune disease, something underlying this that causes to kind of rear its head. Just make sure that that's been assessed, because that's something that we can manage and even cause this to go away on its own in that round. Now, you can take it away, Mary. Hopefully we didn't disagree. We'll see.
So I think that I agree with what you said. I think to underscore that how incredibly rare this is. And with that, almost all the data that we have is retrospective, which in and of itself has its own biases. I think that some of the retrospective data look at those that have had radiation that have some better outcomes and longer remission rates, along with having a complete excision. That's older data, and you could argue it either way, that cancer is a microscopic illness, and that can you get the cells that even if the margins are clear, that may be outside, or looking at it as if there's nothing that one can see, do we leave it alone and save radiation for a different time? And so I think that it all depends a little bit on where it is, about patients' comfort levels and the like. But I always send our patients to radiation oncology to at least have the conversation and have them look at the area in terms of if there's any sort of residual nodularity or the like, and then have a one-on-one conversation about what the risks and benefits are.
Should MOGA and photopheresis be used simultaneously?
So this is an this is an investigational question. A number of people have been looking into this, and we are still coming up with what are the toxicities related to combining the two as opposed to doing them kind of in series. But a number of people have wondered about kind of, can you enhance T cell activation in terms of improvement in the disease, and or could you jumpstart some of the ECP by clearing some of the cells prior to or earlier on than ECP, since it usually takes about 6 months to work. But as always, whenever we do something, is looking at it scientifically to make sure there aren't some unintended consequences that we're just not aware of.
All right, thank you. With patients being treated with MOGA, how long have you seen consistent efficacy?
So if we're talking anecdotally, there are always a set of patients that respond that can respond for years. I can remember one person in particular whom had 10 or 11 lines of therapy that unfortunately was in the hospital every couple of weeks for an infection of one type or the other. And when MOGA first was made available, this was kind of the best thing that she could tolerate, and she ended up staying out of the hospital for and living another 2.5 years with the mogamulizumab. So a lot of people are also looking at, back to some of the earlier questions when we talked about kind of triggers or targets, about why some people's disease, I should say, can be hypersensitive to mogamulizumab and trying to sort out whose disease can be more sensitive. But we have seen incredibly long-term remissions.
I have recently advanced to B1. What are the available types of treatment and long-term prognosis? Dr. Sethi, do you want to take that one?
Sure. Yeah. So that's again a very good question. So B1 means that there is some amount of blood involvement. Again, it could mean that the patient is developing Sézary syndrome. It's based on the number of cells that are seen in the blood. So there are certain agents that work particularly well when there is disease in the blood compartment. One of them is mogamulizumab, which is an antibody drug against a surface protein called CCR4, and then we also have other agents like brentuximab and also gemcitabine, some of the other drugs that work. Also, we know that ECP works very well in the blood compartment. In terms of prognosis, again, the level of blood involvement really is shown to drive the prognosis. Like we know patients who have B2 disease, which is more than 1,000 Sézary cells, they really do have much worse prognosis and a shortened overall survival as compared to those that have B1.
Can you please speak more about clinical trials with ECP? Dr. Sethi, how about this one?
Sure. So, ECP treatment is available as a standard of care, especially, in more advanced disease, including Sézary syndrome. However, there are a few trials that are looking at combinations. For example, with mogamulizumab, again, that's a drug that has particularly good efficacy in Sézary syndrome. And then there are some other studies that are basically evaluating ECP in a more structured way to look for, a particular to gather more particular outcome data, but it's still being used like as a standalone therapy.
What treatments have proven most effective for skin itching? Dr. Girardi?
Yeah, as the dermatologist in the room, I guess I'm getting this question. And this can be a real challenge. Some patients, a lot of patients with CTCL have incredible amounts of itch. The medical term for that is pruritus, and it can be very challenging to control. First, we try to control the disease. So treat the disease appropriately using single or combination therapies. But there are some kind of tricks that we've learned over the years about which particular treatments may be more likely to help. One of them is phototherapy. Narrowband ultraviolet B therapy is quite effective at helping to control itch in CTCL patients across many types, but especially patch plaque early stage 1A and 1B. The other thing is topical corticosteroids. So that's the one that comes in a large tub is triamcinolone, but there are many different types of corticosteroids of varying strengths and varying vehicles, meaning gels, ointments, and creams. And to match that and help coordinate that with a patient's preference can be very helpful. There are some topical over-the-counter anti-itch creams that are available that some patients find incredibly effective. One made by Eucerin, one made by CeraVe, and one called Sarna. And these can be quite cooling and helpful for patients and give them relief and not have concerns about how many times they apply it. There's an old tried and true regimen we do called open wet dressings. This is real simple, completely safe, and anyone can do it at home. And that's getting undressed, taking a bath sheet, wetting it with lukewarm water, and putting it in single layer contact with the skin, and just letting it stay in contact for about 10 minutes. And what this does is it drives a little evaporation, and evaporation is very much a cooling process on the skin. So it constricts the blood vessels and really can give tremendous relief of itch in a very safe emergency way for any patient to be able to do. And right after that, applying some of the anti-itch or cortisone cream like triamcinolone can be a 1-2 punch to really help decrease that itch too. There are also some pills that can be quite helpful, but really I like the skin-directed modalities the best.
In your experience, is extracorporeal photopheresis effective for stage 2B? Dr. Girardi?
Yeah, I think that extracorporeal photopheresis is really it's a treatment of the blood. Its biggest experience is with patients with blood involvement, regardless of what else might be on their skin. But for patients who have tumors on their skin, photopheresis alone will not clear those patients. So that would only be appropriate in the setting of combination therapy. We often will work with our therapeutic radiologists, including Dr. Lynn Wilson and others at Yale, who will effectively flatten those tumors, and really with total skin electron beam can clear the skin certainly very effectively in a matter of months. And we'll do that in combination with photopheresis, and it, while there's not a ton of data on clinical trials in that regard, there has been some over the years that has shown that there's good synergy by combining them and improving survival in this way. And if you think about what's happening, it makes a lot of sense. When the skin is irradiated and tumors and plaques are treated in this way, a lot of the cancer cells will be released into the bloodstream. And then photopheresis can serve as a way to stimulate an immune response against those components, first of the dying cells, but then also potentially transferring that immunologic efficacy to the live cells. And so, while there's not a ton of randomized controlled trials, which are really the standards by which to make judgments and answer these types of questions, I think there is good world experience on combining photopheresis in many settings, including those in which we irradiate tumors.
I underwent 16 rounds of brentuximab vedotin from 2021 to 2022, but is now back with full body plaques and red hive-like rash spots. What treatment may be most effective at this point in my battle? I had 6 rounds of brentuximab 2 in 2008 and did TSEBT in 2019. Dr. Foss, would you like to take this one?
Oh, okay, so this is, can you put the question back up? Okay, so basically, this is a patient who had brentuximab, it sounds like plaques, but not tumors. And then had radiation, I think, most recently. So I guess I would ask the question of where you're at with your disease right now. It all depends on, again, the different compartments, as I just talked about. So what the characteristics of the disease are in your skin. Is it just plaque disease? Is it tumors? Is there transformation? What's the extent of disease in the blood? Is there lymph node involvement? So I think in terms of thinking about how we make that next treatment decision, we take into consideration all of these different factors, in addition to the treatment that you already had. So one thing I'll say is that it is possible to go back to treatments that you already had if you responded well to them. Say, for instance, like now you're CD30 positive again, you could consider brentuximab. In addition, there are clinical trials, and a patient like this might consider, if there's a clinical trial available with a new agent, this might be an appropriate thing to do. Also, not combination chemotherapy, but some of the single agents that we use. We're now actually looking at combinations of some of the biologic agents with some chemotherapy. For instance, Dr. Sethi has a study where she's combining brentuximab with pembrolizumab. So even if you didn't have an optimal response to brentuximab, perhaps this is a good combination. So again, I think at this point in time for this patient, what we really need to do is sit down and look at the different compartments of your disease, how extensive the disease is and what it is right now, and then what our treatment goals are, what are our options and what are our goals. So if a patient like this is refractory, say, to multiple therapies and has more aggressive disease and tumors and other lymph node disease, this is a patient that may want to see a transplant doctor, for instance, and then think about whether we might be heading for a transplant, maybe not now, but that might be in the future. So again, I think multifactorial situation here that requires, again, the input of colleagues in oncology, colleagues in dermatology, and then perhaps a transplant colleague as well.
Next question, Dr. Barta. Is a bone marrow transplant a cure?
All right. Well, we all know that unfortunately at this point in time, cutaneous T-cell lymphomas are generally considered incurable, except for potentially with an allogeneic bone marrow transplant. So when we talk about bone marrow transplant, we usually have talk about two types of bone marrow transplant. One is called autologous, and one is called allogeneic. Autologous bone marrow transplant is probably really a misnomer because we use the patient's own stem cells, and it just allows us to give high-dose chemotherapy. So an autologous stem cell transplant, unfortunately, is not very effective for patients with cutaneous T-cell lymphomas. It can work in other lymphomas. So for cutaneous T-cell lymphomas in transplant, we're really thinking about an allogeneic hematopoietic or stem cell transplant. So there is a chance of cure with this modality, and it depends somewhat on the disease subtype. Patients with Sézary syndrome have a slightly higher chance of cure than patients with mainly MF or mycosis fungoides. Why don't we do much more bone marrow transplant if this is a potential cure? And the reason is that oftentimes patients can be very well managed with an excellent quality of life and a normal life expectancy, thankfully, with a lot of the newer medications that we have available to treat mycosis fungoides and Sézary syndrome. Whereas with a transplant, we have to balance that chance of cure. That's probably around the 30 to 50% range, depending on a little higher for Sézary, as I mentioned, and a little lower for mycosis fungoides. And that has to be balanced against the complications we unfortunately have to expect with an allogeneic stem cell transplant, which have to do with the fact that the immune system is suppressed significantly, and that makes patients unfortunately more susceptible to infections that could be life-threatening, as well as the fact that there is something called a graft versus host disease. The reason transplant may cure patients is that there is a graft versus lymphoma effect. That means the stem cells that are being transplanted constitute a new immune system for the patient, but that new immune system is the donor's immune system, and that recognizes, hopefully, the cancer as foreign and fights off the cancer, but it may also recognize the host, or the person who is getting the transplant, receiving these transplanted stem cells, as foreign, and then may also attack the organs of that patient, which is called graft versus host disease. So all in all, while bone marrow transplant can be a potential cure, we use it in very select circumstances for very select patients, because always, of course, the risk of the stem cell transplant has to be weighed against the benefit. So in general, the answer is yes, in select circumstances.
My patches always return to the same spot a couple of days after stopping the steroid cream. Is there any treatment that can help prevent them from coming back or keep them away longer? Currently, each patch stage is redness.
Yeah, and this is a common scenario I encounter too. People often say that they stop the steroid and the redness does come back. And this could be, an indication that perhaps this individual spot needed to be just treated a little bit longer with the topical steroid. Sometimes you do have to kind of treat it more aggressively up front and slowly taper off to kind of allow these lesions to stay away for longer. At the same time, it's also normal for this disease to sort of wax and wane over time. So just because it is coming back, it's not necessarily a sign that something is progressing or getting worse. Or it could be a sign that, if you are using your topical treatment, if it was a steroid, for example, very consistently and it keeps coming back, there are other skin-directed treatments that can be considered, other types of topical therapies, narrowband UVB therapy, for example. For thicker lesions, sometimes low-dose radiation is used if it's just a single spot. So many different options that can be considered. But in general, it is fairly normal and typical for this disease to sort of wax and wane over time.
They are currently doing a watch and wait, but just don't know when they should finally break down and do rituximab. They're concerned about the potential side effects from rituximab. So how concerned should they be to try it?
Yeah, I think I just answered the
Yep,
question.
you did.
Right. At some stage, as I said, it is an individualized decision, but we do decide sometimes that systemic therapy is the best next step if they're rapidly progressive lesions or lesions that affect a lot of the body surface area. And then rituximab is usually the treatment of choice. And while, of course, we would consider it a fairly safe therapy compared to many other therapies, there is still a risk of side effects. But in general, as I mentioned, compared to other systemic therapies, Rituxan is probably a fairly safe and usually well-tolerated option. It also depends on how long rituximab is being used in terms of what the risk of side effects are, and often we use very short and time-limited therapy with rituximab in that situation. For example, a 4-week course is very different than if somebody gets a 4 or 6 weeks course followed by maintenance, for example, every 2 to 3 months. It's a different story. But this is a very individualized decision, hard to make that call on as the vignette provided, I'm afraid.